Tirzepatide or Mounjaro for treatment of type 2 diabetes mellitus by Dr.Moustafa Mahmoud, National Heart Institute, Egypt. Welcome, my dear colleagues. In this video, we will focus on the glycemic control effects of tirzepatide in people with type 2 diabetes mellitus. Other metabolic effects of tirzepatide, especially on obesity, will be presented in other video. Please don't forget to subscribe to my YouTube channel. Tirzepatide is a synthetic linear peptide containing 39 amino acids conjugated to a 20-carbon fatty diacid moiety. Tirzepatide is manufactured using biotechnology. The drug received FDA approval for treatment of type 2 diabetes mellitus in May 2022. Also, tirzepatide can be used off-label to treat obesity. Tirzepatide is a first-in-class drug that activates both receptors of the two main incretin hormones, glucagon-like peptide 1 and glucose-dependent insulinotropic polypeptide, which play important role in blood glucose homeostasis. Incretins are a group of hormones that regulate blood sugar. By increasing insulin secretion and decreasing glucagon secretion after meals. The main incretins are glucagon-like peptide 1 or GLP-1 and glucose-dependent insulinotropic polypeptide or GIP. Tirzepatide is the first drug in the class which stimulates the receptors of the main two incretins. Glucagon-like peptide 1 receptors, which present in CNS cells, peripheral nervous system cells, pancreatic beta cells, and GIT cells, and glucose-dependent insulinotropic polypeptide receptors, which present in bone cells, CNS cells, pancreatic beta cells, and in adipocytes. So, tirzepatide, by stimulating the two receptors, acting as dual agonist. First, let us see the effect of glucagon-like peptide 1 receptor stimulation or agonism by tirzepatide on the different metabolic processes. On type 2 diabetes mellitus, the effect is the lowering of blood glucose levels by increasing insulin synthesis, enhancing insulin secretion, improving insulin sensitivity, and suppression of glucagon secretion. On obesity, the effect is the weight loss through the hypothalamus to reduce the food craving, delaying gastric emptying, increasing lipolysis and fatty acid oxidation in adipose tissues, and increasing energy consumption. On cardiovascular system, the effect is a protective effect by decreasing inflammation, improving endothelial function, and improving myocardial contractility with decreasing platelet aggregation and thrombosis. On hypertension, the effect is the lowering of blood pressure by secretion of atrial natriuretic peptide. On atherosclerosis, the effect is the prevention by lowering low-density lipoprotein cholesterol and anti-inflammatory effect. Second, Let's see the glucose-dependent insulinotropic polypeptide receptor stimulation or agonism by tirzepatide on different organ systems. On CNS, the effect is the decreased food intake, decreased body weight, and decreased nausea. On the pancreas, the effect is the increased insulin secretion and increased glucagon secretion. In the subcutaneous white adipose tissue, the effect is the increased insulin sensitivity. On the skeletal muscles, the effect is the increased insulin sensitivity. And finally, the systemic effect is the decreased blood glucose levels and decreased dietary triglycerides. As a result of the combined glucagon-like peptide 1 and glucose-dependent insulinotropic polypeptide receptors stimulation or agonism by tirzepatide, or the dual agonist mechanism of tirzepatide leads to superior efficacy, strong blood glucose lowering, enhanced insulinotropic action, weight-independent insulin-sensitizing effects of GIP, better weight loss through synergy of incretins in the CNS system to promote satiety, better lipid handling through improved white adipose tissue health. The half-life of tirzepatide after subcutaneous injection is approximately 5 days, without need for dose adjustment in renal or hepatic impairment. In animal studies demonstrated the potential of developing medullary thyroid carcinoma. It is not known whether it could occur in human or not. So, tirzepatide should not be used in people with a personal or family history of medullary thyroid cancer or in people with multiple endocrine neoplasia syndrome type 2, because beta cells are destroyed in type 1 diabetes mellitus. Tirzepatide should not be indicated for use in patients with type 1 diabetes mellitus. Indications of tirzepatide. Tirzepatide is currently implemented as a second line of type 2 diabetes mellitus medication. In USA, it is used as adjunct to diet and exercise to control blood glucose levels. In Europe, it is used as monotherapy or in combination with other anti-diabetic drugs to control blood glucose levels. Tirzepatide can be used off-label for treatment of obesity. Tirzepatide is available in a solution with pre-filled single-dose pen for once-weekly subcutaneous injection. The starting dose of tirzepatide is 2.5 mg, with increasing by 2.5 mg every month if further glycemic control is needed. The available concentration of tirzepatide is 2.5 mg per 0.5 milliliter, which is the starting dose and not used for glycemic control. Then 5 mg, 7.5 mg, 10 mg, 12.5 mg, and 15 mg per 0.5 milliliter is the maximal dose of tirzepatide. In the SURPASS-5 trial, once-weekly tirzepatide resulted in significant improvement in glycemic control compared to placebo when both were added on insulin glargine. After 40 weeks from randomization, hemoglobin A1C decreased by 2.11 was 5 milligram terzepatide, 2.4 was 10 milligram terzepatide, 2.34 was 15 milligram terzepatide, while hemoglobin A1C decreased by 0.86 with placebo. Also, hemoglobin A1C less than 7 was achieved in 85 to 90% of patients in the tirzepatide group, while only was achieved in 34% of patients in the placebo group. In the SURPASS-4 trial, once-weekly tirzepatide demonstrated clinical significant reduction of hemoglobin A1C compared to insulin glargine. After 52 weeks from randomization, hemoglobin A1C decreased by 2.1 with 5 milligram tirzepatide, 2.3 with 10 milligram tirzepatide, 2.4 with 15 milligram tirzepatide, while hemoglobin A1C decreased by 1.4 with insulin glargine. Also, hemoglobin A1C less than 7 was achieved in 81% of patients in the tirzepatide group, while only achieved in 49% of patients in the insulin glargine group. In the SURPASS-3 trial, once-weekly tirzepatide was superior to titrated daily insulin degludec, with greater reduction of hemoglobin A1C. After 52 weeks from randomization, hemoglobin A1C decreased by 1.93 with 5 milligram tirzepatide, decreased by 2.2 with 10 milligram tirzepatide, decreased by 2.37 with 15 milligram tirzepatide, while decreased by 1.34 with insulin degludec. Hemoglobin A1C less than 7 was observed in 87% of patients with tirzepatide, while observed in 61% of patients on insulin degludec. In the SURPASS-2 trial, tirzepatide was non-inferior and superior to semaglutide with respect to decrease in hemoglobin A1C. After 40 weeks from randomization, hemoglobin A1C decreased by 2.01 with 5 milligram tirzepatide, 2.24 with 10 milligram tirzepatide, 2.3 with 15 milligram tirzepatide, while hemoglobin A1C decreased by 1.86 with semaglutide. Also, hemoglobin A1C less than 7 was observed in 82 to 86% of patients in the tirzepatide group, while it was observed in 79% of patients in the semaglutide group. In the SURPASS-1 trial, once-weekly tirzepatide showed valuable reduction of hemoglobin A1C compared to placebo. After 40 weeks from randomization, hemoglobin A1C decreased by 1.8 with 5 milligram tirzepatide, 1.7 with both 10 and 15 milligram tirzepatide, while hemoglobin A1C decreased by only 0.1 with placebo. Also, Hemoglobin A1C less than 7 was achieved in 87% of patients in the tirzepatide group, while only achieved in 19% of patients in the placebo group. The use of tirzepatide is associated with some unwanted adverse events. GIT adverse events are the most common, but their incidence is decreasing by use over time. Here are the most common adverse events by order of frequency: nausea and diarrhea, decreased appetite, dyspepsia, abdominal pain, hypersensitivity reaction at the injection site, severe hypoglycemia if tirzepatide added to basal insulin, pancreatitis, acute gallbladder disease like cholelithiasis and cholecystitis. Thank you for listening. Please don't forget to subscribe to my YouTube channel. See you in the next video, and goodbye.